Hello everybody, thank you very much for joining us for today's webinar on PIMS TS. I'm just going to share my screen for a couple of introductory slides and then we'll move into the main part of the webinar. All right, go back to the first slide. Okay, so thank you all so much for joining for today's webinar on PIMS TS, Where Are We Now? The webinar has been coordinated by the North and South Thames Paediatric Networks, the One Heart CHD Network, and the Guy's and St Thomas's and Evelina London CHD Network. We hope that you will find the webinar and individual sessions helpful and informative. We all know that PIMS TS cases are increasing across the UK at the moment, following in the wake of this winter's COVID-19 surge, so it certainly feels timely. I'd just like to thank all of our speakers for taking part today and all of you for dialing in. We've got a couple of housekeeping points to make, just starting off with the fact that your microphones and cameras won't work within a live Zoom, but please do ask us questions live either in the chat box or using the Slido link, which we circulated on the poster and which will remain open throughout. We'll address questions at the end during the panel session. Please do be patient with us if we experience any technology glitches. I think we're all learning with Zoom and online learning. We will keep you updated if anything goes wrong. We've got breaks built in, so it should be fine, but please do bear with us. We are planning to circulate links to recordings of the webinar afterwards, so it will be available online for you all. And then just finally, I'd like to make the point that the views and treatment options presented are those recommended by the speakers, and they're not intended to replace the professional judgment of individual clinicians. Clinicians should use their knowledge, experience, and assessment of their patient in clinical decision making. So just to bring you to the programme, hopefully some of you have seen the programme that we've circulated. I won't go through this in detail because you'll hear all of the speakers as they come. But in terms of what we're planning, the first part of this afternoon will focus on the initial instances of the condition, the sort of first identification, recognising a new disease, classifying it, bringing together national guidance with the RCPCH, the experience of retrieval teams, management in PICU, general paediatric management, and then specialties including neurology and rheumatology. And we're really pleased to have some reflections of a parent and two of her sons who have had PIMS TS and who received care at Evelina London and have thankfully now been discharged and are very well. So you'll be hearing from them later. After a break, we will move on to a section focusing on cardiology, which is such an important part of PIMS TS management. We'll have a session focusing on what we've learned from the entirety of the experience of PIMS TS and how management has changed during that time. And then, as I said, we'll end with a panel question and answer session where we'll take questions from you that you've been submitting throughout the webinar and those that we've already received in advance. The panel that I've included there is really varied. We're really happy to have had so many people who've been willing to speak to us, and it may be that other people who present during the afternoon will stay for the panel as well. So that's it in terms of an introduction. I'm now going to hand over to Kate Plunkett-Reid, who's the manager for the North Thames Paediatric Network, who's got some questions for you from us.
Hi, good morning, everybody. Just like to echo what Harriet said and say thank you to you all for joining us. It's fantastic to see such a large number of people. So we do have a few questions that we want to put to you all just to get a flavour of who's joined us today. So I'm just going to pop some poll questions up onto the screen. Now, I know that this doesn't sometimes work for everybody just depending on their access. So if you cannot answer the poll questions, then please feel free to put your answers in the chat box. So let's begin. So our first question today, we just wanted to get a flavour of whereabouts in the country you're working. So give you a few minutes just to respond there. There should be plenty of options. And if you fall outside of any of those categories, please feel free to just pop it in the chat box to us all. Okay, wow. Just give a few more minutes. I can see that the answers are coming in. I don't think I've ever quite done a poll that's had quite so many people answering, so it's taking a few minutes. Right, I think I'll end polling there on that question. So, wow, so as we would expect, it seems that the majority of people are joining us from London, and obviously, as most of you will be aware, we're a London-based team joining up both our North and South Thames paediatric networks and the outer fringes. So we've also got a lot of participants from the Midlands, Northern England and Southern England, but really good to see some people from Northern Ireland, the rest of the world. Thanks everybody for joining us. So we'll stop that one, that's the intro question, and then we'll carry on with the next question. So, so next we just wanted to know, what is the age generally of patients that you care for? So there is an option at the bottom there if you don't care for patients and if you're not patient facing. So please feel free to click on that if you've joined us today from outside of a clinical role. So I can see, just whilst people are answering, I can see that a couple of people in the chat have said that it looks like our attendees are full. So we aren't, I don't think we can increase the capacity of attendees. I mean, it's amazing to see so many people joined, but I know that people will come and go. So please ask people to keep trying, and we will be making this available as a recording for those that aren't able to join. Right, so I think we'll end that one there, share the results. So being a paediatric focused webinar, it's not a surprise to see that most people work with the 0 to 15-year-olds, but it is interesting to see that we have got some other colleagues joining us today that care for other ages and also for adults by the looks of it. Okay, so move on to the next question. So how would you describe your role? So this is about your role that you play in medicine, to give us a flavour. I can see just from the previous question, a couple of people have put in the chat that they care for all ages. Yeah, I'm sure there's people working with all patients. Some paramedics. I can see the paramedics. Sorry, we didn't have a paramedic option in this question. So radiographers, fabulous to see so many different people with us, pharmacists. Okay, so there we go. So lots of consultants joining us today. Children's nurses, junior doctors, and then a smattering of AHPs, nurse educators. Okay. So now on to the PIMS TS related question. So we're interested to know how much exposure you had in PIMS TS in 2020. So in last year, we're going to come on to this year in a moment. So how many PIMS TS patients did you see or did you assist in perhaps treating clinically in 2020? So the majority of you seem to have seen somewhere in the region of 1 to 5 cases. So hopefully today will be incredibly useful for you. We're predicting to see more cases. We're already starting to see more cases coming through. But quite a few of you that haven't seen any PIMS TS cases. So let's look at this year then. So the same question again. How many PIMS TS patients did you or are you seeing or assisting in treating clinically at the moment this year? I can see somebody's written in the chat that they're an orthopedic surgeon, so that might explain why they're not actually seeing PIMS TS patients currently. Okay, so just sharing those results with you again. So again, it's the same, seeing 1 to 5 patients is the number that most people seem to be seeing currently. So the next question, in treating or supporting the treatment of PIMS TS patients, did you have enough resource or access to expertise as you deem necessary to safely treat your patients? Right, so it's really good to hear that actually 82% of you do feel that you are having enough resource or access to expertise. So that's really fantastic to know. And hopefully today we'll just go further to strengthen that. And on that note, the next question. In treating or supporting the treatment of PIMS TS patients, would you or your colleagues find it helpful to be able to access more training or educational days like this? We found in both of our networks that these kind of free webinars, it's just been one of the greatest gifts, I think, of the past year, that we've been able to offer training that allows people to do it from home, from the office, from the ward, from wherever they are. So we certainly plan to continue to deliver such educational sort of training and sessions, but it's really good to have your feedback on that. And I can see in the chat, people are again sort of asking, I'm afraid, because this is a free session, we're using our free account, there has been a limit to the amount of people that can attend today, it would appear, but we will make, this is being recorded, so we will be able to make this widely available outside of that. So yes, 99% of you find this kind of webinar useful, so that's great, and we hope to provide many more sessions. I know that it's already been mentioned to me, could we potentially do something on long COVID in the future, etc. So I'm sure there'll be plenty more that we can do. And then one final question. If that is the case, would you prefer kind of full day sessions, or would you prefer a shorter sort of 2 to 4 hour session? We have obviously today tried to combine things as a whole, but I guess we could break things down further, do separate cardiology things, do separate things for retrieval teams, for example, ED departments, but it's be interesting to know your thoughts. But please do feel free today, if there's sessions that you're particularly interested in, please feel free to dip in or to dip out. Or those are asking about the schedule. What we'll do is I'll try to pop the schedule into the chat for those that haven't got a copy of it. I think Harriet did share it just at the beginning, but I will try to make that available to everybody so you can see what time the different sessions are. Okay. So the majority of you have said that you would prefer shorter 2 to 4 hour sessions. So we will look at how we can do that in the future. So that's all from me, and that's all of the poll questions. Thank you ever so much. That's really informative and will help guide any future sessions that we put on. I'm going to hand over now to our first presenter, to Dr. Shelley Riphagen from STRS, from the South Thames Retrieval Service. Shelley, I'll hand over to you.
Just unmute myself. Can you hear me?
That's perfect, Shelley, yeah.
Okay, let me just see if I can get my screen up.
We can see your screen, Shelley.
Yeah, I've got multiple screens here, so let me just see if I can turn off the other one.
We can see the overview at the moment.
Yeah, I'm just trying to turn off the other one. Sorry, I'm not quite sure how to do that. This one hasn't got the other screen hasn't got a on and off button, so it's not on my. Oh, there you are.
Yeah.
Is that still just the overview, or?
No, that's both. But I think if you maybe go to the top, can you see display settings? Maybe just above your presentation. I think maybe you get a few options there.
There we are. Thank you very much, Imani. And hopefully you don't have the drilling now going on. Oh golly, sorry. So I'll try and speak above the drilling. So I'm just going to give you a short overview of sort of what happened, which seems like, you know, an age ago, but in fact was less than a year ago, where we obviously were able to recognize this new disease. And then at the very end, just look at whether it looks any different then as to what it looks now. So I think all of you will remember back to the end of 2019 when we saw the first cases of COVID being described in Wuhan. And I think most of us were quite horrified at the rapid spread across Asia and then into Europe, affecting ourselves in the UK and then on to the US. So by April, we were all involved in this disease. But I think most of us as pediatricians certainly were lulled into a sense of security that actually it wasn't going to affect children severely, if it did affect children at all. And certainly it didn't seem like it was anything that we should be worried about. But in London during that time, in the early part of April, we had a huge burden of disease in central London, and obviously the hospital Evelina is located opposite Westminster, so right in the middle of this very kind of hotbed of COVID. And at that time in April, we were certainly, the adults in our hospital were starting to really take a lot of strain. They were under increasing pressure. The first COVID cases started arriving almost like HCID cases to our A&E, which we can see from our windows. London emptied, and at the same time, because of the massive escalation in the numbers in London, we evacuated the PICU, our 20-bedded PICU, and relocated to a different area. And the reason for that was that we were having to go from surge capacity to super surge capacity. And you can see this is one of the status reports in early April, when some of the surge areas were already at 100% capacity in the building, but they'd opened up, instead of there being 3 adult ICUs, there were now, you know, 7 or 8 different adult ICU pods, and the PICU became one of those pods. So we relocated up to, we've got two sites of PICU, so a 10-bedded PICU, which is on the same floor as an 18-bedded cardiology ward. And we unfortunately made our cardiology colleagues leave their ward space as well. And we took over the whole 28 beds. Obviously it's ward area, but we delivered level 3 intensive care, including ECMO in that area. And our lovely you know, PICU downstairs was the accommodation, although it's only 20 beds, it was the accommodation for 34 adults. But at that time, STRS was actually still very quiet. And then at the end of April, we saw, we had actually probably early on in April, we didn't recognize, but then we had this child who was a 14-year-old boy who had the typical history of sort of toxic shock, who wasn't getting better locally. And we eventually got called for him because he was starting to become significantly cardiovascularly compromised with a falling blood pressure. They noticed cardiomegaly on X-ray. And so he was referred to STRS and retrieved. And during his retrieval, he had various, arrhythmias, and the arrhythmia was refractory to all treatment, and that progressed on to refractory shock. And at that point, with our backs kind of against the wall and preparing for ECMO, we started him on steroids, sort of shock dose steroids, and then he progressed on to VA ECMO. And actually, in retrospect, I think probably the steroids worked quite well in that setting. We know that they are very important in this disease, and he was weaned quickly off ECMO in the next 4 days, but he remained unconscious. And unfortunately, on CT scan, which we were able to do at that point, he had a massive left MCA infarct, which progressed rapidly to brain death. And so he was extubated and died on the Friday. And then for the rest of that weekend, in quick succession, we had a number of children from exactly the same area in London that looked exactly the same as this little boy. They were all sort of a toxic shock type picture. And so by Monday, we had 5 cases that looked very similar. And why that was so unusual is because if you look at the kind of the STRS referral pattern for sepsis, we have sort of year on year between 100 and 150 sepsis all-comers cases per year. But you can see that in 2019 to 2020, we had this sudden escalation because we were calling this, we didn't know what it was. So we were calling these children kind of toxic shock-like children. And you can see that in 2020, we suddenly got a massive surge, and it started really that weekend. And so we became very alarmed that this was something related to COVID, especially as 4 of the 5 first children all came from the same borough in London, but they were all in central London. And so that quickly escalated to these are our PIMS TS children, and we probably actually we've just cleaned the database again, looking for them on the forms. But this is kind of a reflection of our PIMS TS experience over 2020, and then starting in December again, the cases ramping up, and certainly now escalating very quickly in January. So what did those children look like? And I think you all have experienced them now, or many of you experienced them. They're not like any of the typical diseases we've seen before. They're kind of a mixture of Kawasaki, secondary HLH, and toxic shock, with features of some or all of them in their disease presentation, and so making it very, very difficult to differentiate from toxic shock or Kawasaki in the younger children. So what we had identified then, that actually they didn't fit into any of the diseases that we knew well purely. They were a kind of a mixture or crossover, and they really were just displaying what we felt was kind of uncontrolled hyperinflammation to what we presumed was previous exposure to COVID because of where they were coming from in London. And in fact, all those children in that first wave, we did their antibodies, and by this sort of by the second week after we admitted them, we had confirmation that they had all had COVID exposure. They were all antibody positive. What we saw in those children, and I'm sure many of you have seen this before, and I don't have anything new to say really, is that these children were there was an overrepresentation of Afro-Caribbean and Asian children, which does not reflect the population of London, and certainly that was mirrored in the racial mix that we were seeing across the country, with Afro-Caribbean and Asian adults being overrepresented in the hospital admissions and the mortality. The children, many of them had evidence of systemic inflammation with fever, rashes. They were coming in edematous, even though they had had no volume resuscitation. They obviously were very lethargic, and many of them had reasons for that lethargy, which I'll go into in a minute. Hardly any of the children that we admitted in that first wave actually needed any significant respiratory support. A few of them had cough, but actually they didn't need to go on any, form of ventilation. We did land up ventilating the first, few, because they were shocked and we couldn't get control of the shock. But as soon as we worked out how to get control of the shock, we stopped ventilating them because they didn't need ventilation from any other reason other than we were trying to support their shock. From a cardiac point of view, that was probably the most striking feature, was, these kind of variable arrhythmias that would happen. You'd have all kinds of different arrhythmias in a single child in a single day. And they were often very compromising and not really responsive to kind of normal therapy. A lot of the children had very poor cardiac function documented on echoes, and we'll hear about that later on today. And a very significant proportion of them were shocked at presentation, needing volume resuscitation, to which many of them did not respond favorably. So if you think of your normal toxic shock child who responds well to large volume resuscitation, these children did not like that form of resuscitation. So we had to kind of modify our advice to our DGHs. And then obviously the very, very alarming thing, which we recognized pretty quickly and with very close collaboration with our cardiologists, was that there was a lot of coronary involvement, coronary angiitis with very inflamed coronaries, dilated coronaries, ectatic coronaries, and significant coronary enlargement with aneurysm formation. Not all of those children actually had elevated cardiac enzymes, but some of them did, and some of them had very, very elevated cardiac enzymes. And then we had a few children who also went on to need both cardiac and respiratory support via ECMO. The other thing that I think was striking in this group was the majority of them presented with gastrointestinal problems, with either diarrhea or vomiting or both, and a significant number with significant enough abdominal pain to be operated. And there were case reports from a number of centres saying that they had operated what looked like atypical appendicitis, but in fact they had a normal appendix on histology. And so we quickly alerted our surgeons to the fact that we would have children presenting like this, and they probably needed different typed imaging before they were taken to theatre. In terms of laboratory findings, I wish we had something that would identify these children absolutely, but I think they remain a really careful kind of clinical review, and that obviously is very difficult because they are often quite sick. And so do you keep them locally, or do you bring them into a tertiary center, because obviously they have sometimes unrevealed cardiac problems. But I think the most striking features for me, and I think John will talk about this later, are most of them are lymphopenic and significantly lymphopenic. A lot of them are thrombocytopenic, but not all. Most of them, the vast majority, are very significantly hyperfibrinogenemic, which is very different to normal sepsis. And a lot of them are hyperferritinemic. They have high D-dimers, suggesting there is kind of a vasculitis with a low-grade DIC, and some of them have very, very high D-dimers. And then they also do have significantly elevated CRP and PCTs, despite having no bacterial cultures. And obviously that's very different to our normal viral or post-viral infections, where the CRP and the PCT are not usually that elevated. And then, as I said previously, some of them do have elevated cardiac enzymes, although that isn't necessarily a discriminator for an abnormal echo or reduced cardiac function or aneurysmal dilatation. And I think the cardiologists will talk about that later. So really, just to finish off, I think I've just looked at, these are just the first 23 children we had in the beginning of this disease that we described. And then obviously this next kind of peak, I've taken just the first 3 weeks of January up until Friday last week. And you can see that they're about the same age, maybe slightly heavier, but probably not anything significant. There was a preponderance of boys in the first wave, but actually that isn't the case any longer. Caucasians are still underrepresented in the group, and the clinical presentation is very similar. You would hope we got better at recognizing them earlier, and maybe we're recognizing them a little earlier, but actually it's about the same. And otherwise, the presentation is exactly as we described earlier. They're presenting with headache, abdominal pain, diarrhea, and vomiting. There are still a very significant number of them that are coming into their district general hospitals shocked, requiring volume resuscitation and then inotrope, institution of inotropes, and the amount of children requiring inotropes is about the same as the first wave in these two little groups that I've shown you here, and that obviously is only a very small number. So obviously you make your judgment from that. But I think what we have got better at is we have got better at recognizing that they will have significant abdominal pain, and that isn't necessarily appendicitis. It needs proper imaging to decide whether you take them to theatre or not. But as I said to you before, there is no magic bullet that I know of that you know, in terms of a test that you are able to say this child definitely has PIMS TS. It's a clinical judgment and clinical review based on repeating numbers. And what you do see is that these children, you know, start with an elevated CRP, and despite being on appropriate antibiotics, in the next couple of days, the CRP continues to escalate. And that's, you know, kind of, I think, the trigger point that people should be thinking, this is probably not your barn door sepsis, but it may well be a PIMS TS. So I think the ongoing concerns, and I think it'll be dealt with in the talks to follow, and the questions that remain to be asked are: these children are difficult to triage on the phone. They are children that kind of need serial evaluation. Where is the best place to do that? Because you don't really know necessarily from the referral information whether they necessarily have cardiac involvement or not. It's very difficult to tell. You know, is this PIMS TS, or is it one of our normal pediatric illnesses? Is this a child with our usual toxic shock or septic shock or myocarditis, or is this PIMS TS? And as I said, I don't know what the answer to that is yet. And you know, obviously we have the surgical children. Is this, obviously appendicitis is quite common. Is this appendicitis or is it PIMS TS? And how do we, you know, try and avoid unnecessary laparotomies in children with PIMS TS? And I already alluded to the cardiac involvement, and hopefully we'll have a little bit more insight from our cardiologist later on today. And then the last thing really is that I think probably by the end of today we can have some kind of consensus in terms of what is the trigger to remain in a DGH and what is the trigger to be transferred. Obviously there are clear triggers like ventilation or inotropes or large volume resuscitation or not getting better, but which are the children who, you know, we're more worried about than not. So that's all I really had to say. I think everybody else will be covering other aspects of, so I'll leave it to the other talkers, not steal the other speakers, and not steal their thunder. And I'll leave the questions for later.
Thank you so much, Shelley.
No problem.
Oh. We're seeing lots of comments about reaching the limit of attendees. I'm really sorry about that. As Kate said, this is a free event, and so we're limited to 500 attendees for this. We will make sure that recordings are available online after, and we are trying to sort out a Facebook live stream for which you need to use an NHS email address. Kate has just put that comment in the chat. If there's any way of contacting your colleagues who are trying to get in and let them know that, then please do, and do share that link on with them. So
Harriet, sorry, Harriet, just to interrupt you. We had one question from a clinician called Sarah Fleet wanting to ask Shelley, do we know why these children didn't respond well to fluid resuscitation?
I mean, I'll give you my opinion, but I'm sure there'll be lots of other clinicians that will also be able to speak to that. I think probably they have significant myocardial impairment, and so they really are a child with, you know, a kind of an inflammatory condition, but they're like a child with cardiac failure. They don't tolerate large volume resuscitation. So you have to be very careful when you resuscitate them. Obviously, you still do try volume resuscitation, and, you know, you start with 10, 20, 30, 40, but most of the children that we are seeing are, you know, they're getting up to sort of a maximum of 40 mils per kilogram and then going on to inotropes, whereas that is not how we would normally, you know, manage toxic shock. We would normally land up giving large volume resuscitation to toxic shock, and they wouldn't bat an eyelid. They wouldn't be no pulmonary edema. They tolerate the fluid without any cardiac compromise. So I think that is probably the reason, but others may have, you know, other suggestions.
Brilliant, thanks, Shelley. So our next speaker is Dr. Hermione Lyle, a consultant in paediatric infectious diseases at St Mary's Hospital and the co-clinical director for the North Thames Paediatric Network. Thank you, Hermione.
Thanks, Harriet. And I think Kate has got my slides. I hope she's going to start showing them. But I completely agree with what Shelley said there. It does seem to be a myocardial function problem that is very important for these kids. So my first slide goes back to the time when Shelley was talking about, and here we go. Okay, and you can just click them all on there, Kate, so we get everything on the slide. And I was asked to talk about moving on from the first few children who were identified, first of all in South London, then, and I think this is interesting because it followed the way that COVID went around London, that it was more in the south before the north and the east. Then we began to see similar children coming in the north and the east. We reported this to our colleagues at NHS England and the Royal College of Paediatricians, and we felt that it was very important to try and develop a case definition that would help us to try to understand what was going on. Next slide. And as we were seeing this, actually colleagues all over Europe were seeing similar things. And focusing particularly on the Kawasaki side, but also pediatric shock and myocarditis. Next slide. And the French, who are always great researchers and epidemiologists, were onto this quite quickly. And you can see here the map of France in the ochre color COVID hospitalizations, and in the blue color, children presenting with PIMS. And the hottest COVID areas were the areas with the most children with PIMS. Obviously not causal, but a very nice demonstration of a probable link. Similarly, next slide, our colleagues in the USA very soon saw the same sort of thing, adults presenting with COVID, and then in the month or 6 weeks subsequent to that, children presenting with inflammation. We were calling it PIMS in the UK, they were calling it MIS-C in the US. Next slide. So very quickly, there were a plethora of publications from all over the world about a novel kind of Kawasaki's, a novel kind of shock, and multi-system inflammation. And as Shelley pointed out, what was very interesting is that there did not seem to be any children in China who presented with this. And I haven't seen any follow-up on that subsequently. Next slide. So when we began to think about this with our colleagues in the Royal College, our epidemiology and research colleagues, we wanted to think, look at a case definition that would be broad enough that we wouldn't miss cases, that it might well include other conditions that might be related, but this would give us an opportunity to have a kind of baseline surveillance, and that we would then be able to promptly and early start getting children into cohorts for follow-up and research studies for management. It was clear to us that some of the children were actually PCR positive at the time of presentation, but that was a minority. And even in the early days, most places didn't have access to serological testing. So it wasn't going to be absolutely that they had to be PCR positive. Next slide. So you can see here the case definition that we came up with from the RCPCH. So it talks about the fever, the inflammation, organ dysfunction, abnormal blood tests, and that some children would be fulfilling the criteria for Kawasaki's. It also importantly makes the point that you don't find any other bacterial or microbial cause for the infection. And SARS-CoV might or might not be positive. Next slide. So the Americans, for their MIS-C, can you just move it on there? Yeah, for their MIS-C, or if you can just go back one, for their MIS-C definition, they actually were more defined about having either a positive PCR, serology, or antigen test, or definitely some recent symptomatology or contact. Next slide. There is now a WHO definition which goes up to 19 years of age, 3 days or more of fever, highlights two of the following: rash, red eyes, red lips, shock, myocardial dysfunction, coronary abnormalities, abnormal cardiac enzymes, coagulopathy, and GI problems. And alongside that, raised inflammatory markers, no other microbial cause, and evidence either of positive tests or contact. Next slide. So I think that is pretty clear. And I'm going to go through some of the early studies which include our own children in London, but this is one that came from France and Switzerland. And this highlights in red the elements which are similar to Kawasaki's disease, but in black, the ones that are different. And what is interesting here is that in this early French cohort, all of the children had LV dysfunction, and actually nearly a third of them went on to ECMO. And I think that may be because of relatively late diagnosis. Now I hope we are diagnosing this earlier, and I think encouraging from Shelley's slide of last spring to now is to see that the number of days has actually got shorter, because it may be that if we can intervene earlier, we make it less likely that children are going to progress, although I don't think we totally know that yet. Next slide. So Ram and colleagues from the PICU group in the UK, they put together a publication which was in the Lancet Child and Adolescent, and they had 78 patients here. There was a male preponderance. Importantly, this cohort is older than you see in Kawasaki or Kawasaki shock. They were often a bit overweight. And again, we saw this preponderance of children of Afro-Caribbean and Asian origin. In this cohort, 23% of the children had coronary artery dilatation. And overall, something like a third of children during that first wave were admitted to PICU. Next slide. So, and this just shows you the numbers that spike at the end of April, beginning of May, when the PICUs suddenly became very busy, and the UK map, which was also demonstrating that these children were in the areas of the highest prevalence of coronavirus at the time. Next slide. So this is the publication that many of us who are here today have been involved with, where we tried to go in some detail into the first 58 cases that were mostly from London, but also other centres in the UK. And again, it demonstrates the male preponderance, the Black and Asian children. The median age of this group is around about 9. And comorbidities were rare and probably not related. Next slide. And what did we see? So I think these children, at least half of them had red eyes and rash. Abdominal pain was very common, vomiting and diarrhea, lymphadenopathy, headaches, swollen hands and feet, less so. About half of the children ended up in PICU, and half of them were on inotropes. A fifth of them had an acute kidney injury, and a smaller proportion were ventilated, and that became less as time went by. And in this group, about 14% of them had coronary artery dilatation. And Shelley already mentioned some of the very impressive laboratory abnormalities that we've seen in these children, and CRPs that were going into the 300-400s, very, very high numbers. These children also become very significantly hypoalbuminemic too. Next slide. and a proportion of them were PCR positive, just about a quarter, but the majority of them had evidence of exposure to SARS-CoV-2 and were antibody positive. Next slide. So this is a very nice table that's put together by my colleague Liz Whitaker, and the Feldstein paper, this one here, is from the US, and I think they looked at this in a very nice way, looking at the combinations of different system involvement. And really the hottest one of all is GI. So almost all the children in their cohort were presenting with some kind of GI symptoms, but really over all of these, with varying numbers, it's a very prominent feature. And then you can see the other system involvement is over 75% or below. Next slide. So when we looked at our kids, we felt that there were 3 different phenotypes. There were the children who really fulfilled the criteria for Kawasaki's, and they were actually a bit younger than the others. And they were treated as we would normally for Kawasaki's. And although they were younger than the others, they were older than the age we'd normally expect for Kawasaki's. One of those children got Kawasaki shock syndrome, and with 2 of these kids got coronary artery aneurysms. Then there were the children who were hot and inflamed, often with a very much abdominal presentation. One of these children also got a coronary artery aneurysm. And then there were the sickest ones, which Shelley was really concentrating on, who ended up in intensive care. 3 of them required ECMO, 1 sadly died, and 5 of these children had coronary artery aneurysms. And you're going to hear a lot more about the cardiac side of it from our colleagues, but I think all of us would agree that these are the kinds of presentations that we're seeing. And I guess the big question is, if you catch a child at this stage, can you prevent it from heading on to shock? And I think that's a really important point. Next slide. We were able to work with Jane Burns, a very well-known worldwide Kawasaki specialist who works in San Diego in the US. And she has a massive cohort of biobank from children presenting with Kawasaki's. So we're able to try and do some comparisons from her cohort of children with Kawasaki's. Also, she has a cohort of children with Kawasaki shock. And within the Euclid's study, we were able to get out data on children who had presented in Europe with toxic shock. When we compared these children, what you could see is that the PIMS children were older and their inflammatory markers were all much worse. But also when you compared children with Kawasaki's in this PIMS era, they were also older than the pre-COVID Kawasaki children, and again had worse inflammatory markers. And of the cohort of kids presenting, the children with shock tended to have higher inflammatory markers. The inflammatory markers were not really discriminatory in terms of whether or not there was coronary artery dilatation or whether or not they met the diagnostic criteria for Kawasaki's. So it's certainly true that these children had more evidence of inflammation, but that didn't necessarily help to pin down what was happening with their coronaries. Next slide. So again, this is a very nice way of presenting the symptomatology, and this is from the New York cohort. And here, not only just looking at the different presentation in terms of the organ systems involved, but also the age brackets of the children. And I think it looks, what you can see here is that the younger children are often the ones who are more red, that they all have GI involvement, that the Kawasaki's type presentation is more so in the younger ones, and that the myocarditis type presentation is more so in the older ones. And they've also highlighted that in terms of neurological presentation too. And you're going to hear more about that later as well. Next slide. So I just want to put in a plea as a pediatric infectious diseases doctor. Do remember, we're all going to fall into the sinkhole of PIMS, but do remember that there is still a differential diagnosis. And it's really important that these children get blood cultures, get throat swabs for bacteria and viruses, get a urine dip and a urine test, and that we look for infections. There is, you know, the other red things that make children go red are still an issue, and we need to remember about that. And I just highlight that the London Weekly Report that is normally covered with all sorts of different infections. In the last few weeks, it's practically empty. There's no RSV, there's no flu, there are no other viruses. But there are still occasional cases of invasive group A strep disease, which is obviously very serious and could certainly be a diagnostic dilemma in relation to PIMS. So again, it's really important that these children are started on broad spectrum antibiotic when they present. Next slide. So what are we doing? The Venn diagram here shows you what we did. You know, we think we know how to treat Kawasaki's, so we used that and adapted that to treat these other inflammatory presentations. In that original cohort, there were a group of children who got no treatment and got better. There were a large number who got immunoglobulin, steroids, and a smaller number who got biologicals. Over the summer, many of us took part in a national Delphi process, which I guess is a way of people who think they know what they're doing coming up with a good idea to try and identify what's the best way to manage children, to triage children, even when we don't have any clinical trial evidence to go on. Next slide. And to try and support each other. This is from my own institution, this is our management pathway according to the phenotype that you're seeing. Next slide. And within the North Thames sector, we've also tried to support clinical teams by looking at a safe way of triaging according to presentation and making sure that if a child does have signs of cardiac dysfunction, that they do need to be going to a hospital where there is access to intensive care. If they have the less significant features and they're just in the inflammatory phase, then they may be able to stay where they are. And if they're a Kawasaki type child, they may be able to stay where they are, but they obviously need to be somewhere where they can get cardiac support. But this is difficult, as Shelley said, but I think also we need to bear in mind that, you know, as we get to know and understand this condition better, it may not be necessary for every child to go to intensive care. We've also just recently tried to clarify for our local hospitals where they should call first to get some support. Next slide. So the bottom line, and I'm sure you're going to hear this lots of times over the day, is that we still don't understand the pathophysiology of this condition, and we still don't know how to effectively and as rapidly as possible switch off the inflammation and prevent long-term sequelae. So if you are seeing children with PIMS, please get involved with the research that is going on. The BPSU is our national surveillance, is gathering the clinical data. Diamonds is a study which is looking at children presenting with any kind of infection or inflammation. So it's an opportunity to collect blood samples so that we can look at the inflammatory markers. BATS is a study looking in more detail at the cohort of children and what treatment they've had and their outcomes. So this is a treatment cohort. And very importantly, recovery is a study you'll all have heard of, which is a randomized controlled factorial design trial with Bayesian statistics to help us to choose treatments and randomize children to treatments so that we can see which ones are the most effective. And really, as clinicians, I think it's our responsibility to be doing as much as we can to get these patients into research. And if any of you, there will be discussions later about how to join the research groups. But if you need, I can always put you in touch with any of the researchers. And I think that's my last slide. Thank you very much.
Hermione, while you were talking on the Slido app, there was a question about how many PIMS TS patients have been recruited to the recovery trial. Do you have any answer for that?
I think, and this is maybe from the beginning of January, it's probably going to be more now. I think it's between 130 and 150, something like that. So we need more children to be recruited. I think actually, and I think colleagues from Gosh and Evelina may be able to answer this as well, but a lot of families are not terribly keen on being recruited. So I think the uptake at the moment is only running at about 50 to 60%. So I think being able to explain to families about this condition is actually quite difficult. It doesn't just, you know, it's not an easy thing to explain. And then explaining about the research on top of that is quite complicated. But I think there is good information available for families and for children and young people about the clinical trial.
Thank you so much, Hermione. And just for everybody in the audience, Hermione is on our panel at the end of the session today, so you'll be hearing more from her later on. Our next speaker is Dr. Elise Randall, a paediatric intensivist for CATS, the North Thames Retrieval Service. Thanks, Elise.
Thank you. I'll just get my presentation up. Okay, can you see that?
Perfect, thank you.
Lovely. So I'm taking this from the PICU transport team perspective of what we're getting referred, what our current experience of this disease is, and what we're seeing as the red herrings when we get this disease referred to us. So I'm going to briefly talk about what happened to us at the beginning, but very much echoing Shelley's experience from that first presentation, and then move on to what we saw at the beginning of this, what we are now seeing, our total experience to date, then very briefly on who we think we should be moving to PICU, some of the impact it's had on our transport logistics as a service, and then a suggested approach to this. And just, I know it's a very broad audience for the polls that we had at the beginning. This is the area of the country that that CATS, the Children's Acute Transport Service, cover. Normally we have those 5 PICUs in the region. At the moment, 3 of them are essentially taken over by adult services. And as you see, we do about 1,250 transports a year. So very briefly, as we've said before, back in the beginning of 2020, this is what happened to the start. So we started to see the numbers going up in adults. There was a paediatric escalation plan put in place for London, and we waited to see what would happen. But we were all quite reassured by the Wuhan data that children were not going to be a problem with COVID, and we waited to see what happened. And we got our first COVID positive patient on the 15th of March, which was actually diagnosed post-transport. At this point, we'd started using full PPE for all of the transports, knowing that it was likely to hit, and the adult numbers in London were enormous. So we were protected, but we retrospectively found out that that was our first case.
And then there was a few more incidental findings. So at the bottom there, I've put the chart of the adult numbers in the red columns, and you can see the first 5 children that we had that were COVID positive in the blue arrows. And this is before PIMS-TS existed. And as you can see, the first few children were respiratory. We had apneas in small children and seizures. And then on the 13th of April, we had a child with shock. And then in 3 days, we had 3 children with this hot vasodilatory shock. And we spoke to STRS who were having the same experience that week. And the pediatric infectious disease teams were made aware, and they then put out the alerts and the guideline that we just went through in the previous presentation. And that's what we were seeing. So from the mid-March, we saw pneumonia in children that already had chronic respiratory diagnoses. We then saw these apneas in small children, and then status, both in children that were and were not known to already have a seizure disorder. And then we started to get referred to hot shock, appendicitis, Kawasaki, toxic shock, and that's the cases in the first wave over April and May. And it became the predominant phenotype. So we had the guideline national alert out on the 27th of April. This is looking at our first wave data in June. And you can see that more than 50% of our COVID associated children that are removed to PICU in that wave were PIMS-TS. And this was probably the most interesting thing, is that the orange line along here, we've got the dates across the x-axis. That's the adult numbers on the right-hand side y-axis. But the PIMS-TS cases are superimposed. So you can see that we had the lockdown in the middle of March. Our peak for the adults was in the 28th, 29th of March week. And then we start to see our PIMS-TS cases going up in the middle of April, and they don't peak until the first week of May. So there is a 3-week lag following the adult respiratory COVID wave before we start seeing the peak of our PIMS-TS cohort. And then essentially it plateaus for a couple of weeks before it then starts to come down. So what have we seen now? So this is the data that I pulled this off the database at CATS yesterday. We've had 2 more referrals overnight. So there's a couple of extra children that are not in these numbers, but this is essentially the total experience. This is every child that is transported to PICU with PIMS-TS. So we do also have referrals that are coming through us, but actually ultimately we don't transport them because they're going to a pediatric ID ward or they're staying at the local hospital. So this is not our total referral numbers. This is the ones we've actually moved into a PICU. And I have put there is possible early underrepresentation, because there are a few children referred back in March, April, which we need to go through retrospectively and recode, which is a process that is ongoing, but there's possibly a few cases at the beginning that we weren't coded as PIMS-TS. So this is the headline. We have had a total of 81 patients transported in the year to date since COVID became a thing back in March. The PIMS-TS cases, we had 33 in the first wave and we had 48 so far in the second wave, but you can see we basically finish having any referrals for PIMS-TS. We have July off, it starts to grumble in autumn, and then suddenly, particularly this month, has gone up. And as I say, we've had 2 overnight. We're on average getting 3 or 4 referrals for PIMS-TS every day at the moment. So there's 3 more days of January, and I suspect that that column will be at least 40 by the end of the month. And you can see there's a split there with the girls and the boys. So the boys are in blue, the girls are in orange. And there is a predominance in boys, and actually it was interesting to see the STRS. I've spoken to a member of their team yesterday, but actually we're seeing the predominance in boys again in this wave, rather than it being reversed on this occasion. And that is the boy predominance is in all of the sort of data sets that have been released around PIMS-TS. Where are they referred from? So I think you've seen the COVID wave comes from the south and goes up, and then east and west. And actually, in our first wave, you can see these different areas of London. So northwest, north central and northeast are the 3 sectors of the north area of London. And then we've got the area straight above that, which is Herts, Beds and Essex, and then the area out into East Anglia. The total for the first wave, we actually had more cases from the northwest of London than anywhere else in the end. But on both occasions with these waves, when I've just looked back at the data, for the first week, we only get referrals from northeast London. They seem to see it first, and then it spreads across to the northwest area of London, and then up into Herts, Beds and Essex. So we don't know what the second wave is going to look like. And interestingly, East Anglia got no cases at all of PIMS-TS in the first wave, and they've had their first 2 this week. Ages, again, it's highlighting that these children are around 11 is the most common age to present, but you can see there is a range. We've seen children down to 3 months that have subsequently been labelled as PIMS-TS. and all the way up to 18. So there is a range, but it peaks at around 10, 11 years. And comorbidity is low. It's not quite as low as the previous, the 58 patients that on Liz Whitaker's paper. But these are the children that are being referred into intensive care. So 10 of our 81 patients have had a comorbidity, but they're very diverse. It's around 12%. What do they come in as? So obviously there was a lot of ambiguity in the first wave, and I've written there all of the different ones. The most common thing that they were referred with was systemic infection, but there's a big range: appendicitis, pneumonias, acute febrile mucocutaneous lymph node syndromes, inflammatory responses, and then other infections like meningococcal meningitis, encephalitis, atypical Kawasaki's, and shock. So a big range. In the second wave, in the orange columns, people are much more aware of this diagnosis. So systemic inflammatory response syndrome is the most common thing that we're being called to say, this is what we think the child's got. But as you can see, there's still a lot coming in as sepsis or septic shock, and some as a respiratory tract infection, and some as Kawasaki, that ultimately get a diagnosis of PIMS-TS in the unit. What level of support are we needing? So I've split the waves in June, because that's when we had 0 referrals for PIMS-TS. So the first wave is up till that point, the first 33 patients. And you can see at that point, we had 70% of them self-ventilating in air. So even at that stage, there was quite a high proportion that were not on any respiratory support. But 10 patients, 30%, did need respiratory support. Now, in our second wave to date, 48 patients, so nearly 90% are self-ventilating. So I think that just reflects the recognition that these children don't need that big volume up front. They don't manage it very well, and they need respiratory support if you give too much fluid. And actually, most people are now aware of that and are moving to inotropes early, and therefore are not requiring that respiratory support. So it's a minimum number that are actually requiring intubation and ventilation. And we've moved no children on high flow oxygen or nasal flow oxygen or CPAP. They've all been either self-ventilating or intubated. Vasoactive support. So with the vasoactive support, again, in the first wave, we had 7 children on adrenaline, 2 children on noradrenaline, 6 children on both of those vasoactive drugs, and 18 on no vasoactive drugs. So actually more than 50% of the children we moved were not on any vasoactive support. And I think this reflects that in the first wave, we didn't know what the significance was of PIMS-TS and how dangerous it was to leave these children in areas that didn't have cardiac backup. So there was a lower threshold for moving children into PICU beds with the ability of cardiology to come and review them there. So we were moving children that we wouldn't normally move that were not on organ support. Which I think is why there's such a high proportion of children that are not on any vasoactive drugs, and about 46% are on something. And we were also following the standard sepsis algorithm for the inotropes at that stage, which is why there's a relatively high proportion on 2 inotropes at this point. This time round, in the second wave, you can see there is still about 40% not on any vasoactive medications, because there is still a low threshold for moving these children into a HDU or ICU area when they're needing still volume resuscitation, or they've had any other worries about their cardiac function with very high cardiac enzymes or arrhythmias. But you can see for the other, there is a higher proportion of children on vasoactive drugs, and of that, there is a higher proportion on noradrenaline as a solo agent. And that is because predominantly we're seeing vasoplegic shock, the toxic shock kind of presentation, but there is still high use of adrenaline. And to be honest, we don't know which of those inotropes is the correct approach. And you'll probably hear more about that later on from PICU and from cardiology. But it is an area of research at the moment to try and understand the physiology and know which drug to go for first. And it's always a conversation on a patient by patient basis at the current time. And then finally, PIM3 scores. These are scores that we give to all children that we move into PICU. And it is there's various physiological and kind of historical markers that give you a chance, your likelihood of mortality. So it's the pediatric index of mortality score. And you can see the median and average scores are slightly higher in our second cohort, but that is probably because we are now moving children that are needing PICU more than the children that we were moving in the first wave, where it was a lower threshold for referral. So who are we moving? I've already said in the first wave, we were moving nearly all children with this new diagnosis in case the cardiac function was a major concern. But now the PICU criteria are essentially those that need the organ support. And I think Shelley has already mentioned this. So obviously respiratory support, cardiovascular support is the most common, and children that have just had arrhythmias and things like that that are not currently on cardiac support, we'd still take to the ICU. Renal failure requiring filtration, although that's fairly small numbers. Neurology requiring intubation. Nearly all of these children, when you do EEGs on them, have got mild encephalopathy at least. If they have significant encephalopathy, they may need airway protection. And then COVID is seeming to cause DKA, not so much in context with PIMS TS, but that's the other COVID group that end up on PICU. This disease has had an impact in these following ways on our transport logistics. So referrals, when we had this is data that we had time to look a lot more in depth with the first wave, and our advice calls fell away back in April. So we had lockdown and there was a worry that children were not presenting to A&E. And I think everybody's seen the college alerts go out that encouraging people to seek help with their sick children. But I think actually paediatric attendance in A&E dropped, and therefore our advice calls also dropped at that time. So we did have less referrals after the lockdown there. And times wise, we see a big jump up. So the graph on the left-hand side, you can see our times, and our stabilization time in orange, which is the time that we spend with the patient in the local hospital before moving them, stayed pretty much the same, if not slightly shorter, which is probably the people wanting to get out in their PPE quickly. The grey, PICU to base, is quicker, and that was because as the other PICUs shut down, having to fill up with adults, most of these retrievals were to Great Ormond Street for our team, which is the nearest ICU to our base. But what jumped up is the time out of the door, essentially, and that was all the preparation with the PPE and having to split the kit up into a different system in order to keep clean within these COVID retrievals. And you can see on the right a slow increase in our activation time, which is the time that we expect people to get out of the door once we've decided the child needs to move to ICU. And we always tried to get under 20 minutes and we were successful until COVID. And now we've got QI projects ongoing to try and get that back down again. And obviously there's PPE, we're getting more used to that and we're streamlining our processes, but doffing and donning, particularly if they're coming back to the base in a dirty ambulance, which then they have to doff outside in the car park. We have to wait for security escorts both in and out of local hospitals and into the PICUs, which does take time and a lot of coordination. We're unable to use paperwork anymore, and actually we've moved to electronic records and we can't take laptops into these areas either. So there's additional time for that. And then deep cleans of ambulances, which is slower and by an external company. So all of these things have knocked on to slowing things down, and we are trying to become more efficient again. Communication, I'm sure everyone on this call is aware that with PPE it's become difficult. We've now got pouches for the mobile phones. Paper is a major issue. You realise how you scribble things down a lot when you can't do that anymore. And keeping all the observations from monitors and drug prescriptions has all become a little bit more tricky, and having to have backup for new referrals. So this has all been sort of challenges to transport. And then parents. So we have ambulances that have 2 extra seats in, so we can always have parents with the children when they are transferred to intensive care. And we know that they appreciate that option. And that's been really difficult. At no point have we stopped offering parents to come with their child in an ambulance. But at the moment, we're only taking 1 child, and each trust that we either pick up from or go back and drop off at have different policies which change over time. So that's all been quite tricky. At the moment, we're still able to take 1 parent, and most of the PICUs at least are allowing 1 parent, but they must be asymptomatic and wear a mask within the ambulance. So moving on to red herrings. So I put this section in because I think we've alluded to the fact that we're worried about missing PIMS TS, but we're also worried about assuming it's PIMS TS. So the first wave, we had all that range of referral diagnoses that I've written down here again. And I think it was new and people hadn't seen it very much, and people were not flagging it up as a diagnosis. So it's remembering that this is a thing. What we're seeing now is that everybody is thinking about it, but we do still need, as Hermione's just said, we need to remember that there are other diagnoses around. And in the last week, we've had a child with endocarditis, we've had a child with subdural empyema, we've had a child with invasive group A strep sepsis, and we've had a child that just has straightforward Kawasaki. All of them got referred untreated as PIMS TS. So it is another plea to just remember that the other diagnoses that we always had are still out there, and we need to pick those ones out of this big swing up in PIMS TS. And one of the other tricky things with PIMS TS is that it keeps evolving. So Hermione's already been over the traditional RCPCH definition, and what we were seeing with our referrals for the children that need PICU, so some organ support, are that we see fever, we see the gastrointestinal symptoms and the headache, the rash and the conjunctivitis. But it has mutated. Now in the last couple of weeks, nearly all the children have been hyponatremic, and a lot of them are reporting neck pain. They're still able to move it, but they restrict their movements with neck pain and often have lymphadenopathy on their ultrasounds. And in the last week, we've had three children now that have had testicular pain as a presenting symptom days before they've developed other symptoms of PIMS TS, one of which was initially thought to have torsion. So it's an evolving situation. So my suggested approach is, first, is it PIMS TS? Second, is it anything else that we always had there as a diagnosis? And if it could be PIMS TS, if the child doesn't need PICU, discuss with your regional paediatric infectious disease team. I think Hermione just showed the new guidance that's going out for the North Thames Paediatric Network about who to approach for that. And if the child needs PICU, CATS is the team for the North London area, STRS for the South, but every area of the country has a pick and transport team with conference calls facilities. And we can pull in anybody we need. We can pull in cardiology, infectious diseases. But if the child needs PICU, we will coordinate that transport into the appropriate place. And this comes from my one of my AMPs, who, when I mentioned this talk, was immediately like, please put this at the end. So if the child's got PIMS TS and they are coming to PICU, whilst we're on the way to come and get them, make sure the cardiovascular monitoring is in place and the blood pressure is on at least every 15 minutes. And one of the most frequent things that they would appreciate that we sometimes don't see is the three-way taps on the vasoactive infusions, which makes it a lot quicker for us to start a new one or titrate the ones that they're on. So please put the three-way taps in and make sure we're observing the cannula sites. Peripheral inotropes and vasoactive drugs are safe. They don't have a significant increase in morbidity as long as you have good kind of monitoring of that cannula infusion site. Please prepare the child for the ambulance. As I mentioned, some of them have got mild encephalopathy, and it's a scary process, the whole thing, and they've often moved around quite a lot before they get to our ambulance. So please let them know what's about to happen to them so they're not getting a surprise. And prepare the parents, the fact that they need to have one asymptomatic parent. And if they don't have a parent, we will take other relatives if they have been in a different house and not exposed to a positive child. But one person can travel. And reassure them of that. And if the child's moving to PICU, please send a rapid COVID PCR as soon as you know that the child's coming into a PICU, because there is a lot of logistics around where these children can go inside the hospital, wherever we take them. So it's great to know whether they are actually PCR positive or negative at the point we're transferring them. And then finally, I'll leave you with that. That's taken the graph off the BBC yesterday. It looks like the community numbers in adults are starting to drop down. Unfortunately, as I showed you at the beginning, PIMS TS lags by 3 weeks and then plateaus for 2 weeks. So we are likely to continue to see our rise for another couple of weeks now, but then hopefully the end is in sight and things are going to start to come down again. And I think that is it. Thank you very much.
Thank you so much, Elise, for joining us today. I can see there are lots of questions in the chat. I'm just really aware that we've already ended up 10 minutes behind and we've got lots and lots of speakers. So if it's okay, we will move on. The plan is for us to collect all of the questions together and send them all out to you, to everybody who's attended afterwards. So the next speaker is Dr. John Lilly, a paediatric intensivist at Evelina London, who's going to be talking to us about ICU management of PIMS TS. John, I don't know if you know how to come out of the kind of current presentation style. We just had comments in previous speakers that it makes it a little bit small and difficult to see. I think I
can do that.
Do you know how to do that? Brilliant. You're
Yeah,
much better at technology than I am. If not, I know that Kate figured it out.
Is that better?
No, we can still see
John,
those two slides.
I think you need to use the display setting on Zoom. So if you look at the top of your screen, where it says display settings.
Duplicate slide view, or do you swap presenter view and slideshow?
I'm not sure that's working, perfect. Whichever one which was that one?
Okay.
Was that the first one?
Perfect.
The first one, yeah, swap presenter. Yeah, is that good?
Thanks so much.
Okay, and I'll just start my timer just so I don't run over. Sorry, let me just do that. So my name's John. I'm a PSU consultant at Evelina and STRS. Yeah, so following on from Elise, actually she's done a lot of the hard work in presenting the data, and the ICU admissions in the UK very much reflects that. So, you know, matches the retrieval, so I won't go into that. And the day is where are we now, but actually I do have to talk about have we come from? Because that actually frames where we are now. It puts everything into context. So Shelley's spoken to you already about those first children that we saw. And after people told me that I was crazy to suggest that these kids had salmonella from a single Just Eat outlet in Woolwich, but you know, we're all wrong sometimes. And we actually found out that it was related to the COVID pandemic. The question then came, well, how do we manage these children? And as intensivists, we, you know, our bread and butter is organ support. And so I'll talk very briefly about that and how that changed with PIMS TS. And then in addition to that, we'll talk about immune suppression. And very quickly, we were kind of wrapped on the knuckles at saying that it's immune suppression, and saying, no, it's immune modulation. This is hyperinflammation. So don't worry about suppressing the immune system. You're actually correcting the immune system. And actually, that does make up a bulk of the presentation. And I'm aware that Nick Wilkinson's talking about the rheumatology side of things, but I'll kind of come at it from an ICU approach. So I won't be talking about IL-6 mechanisms or anything like that. And then anticoagulation was kind of the next step in the ICU management. And then there's also something else to say, that there was also a part of management which was communication, in that this is certainly the first time that I've been involved in something where everyone was sharing information on Twitter, webinars, without actually peer review publications. That's how we were learning. So in terms of organ support, we're taught as PICU registrars to differentiate between warm and cold shock. And these children looked like warm shock. So why are they different, or what did we learn, and what are we doing now? The main thing to say is that typically those children that we see with toxic shock who present warm, flushed, vasodilated, they require noradrenaline, huge amounts of fluid, and they have amazing cardiac function. They have normal cardiac function. They often have high cardiac output if you manage adult patients. And these group of patients sometimes didn't respond like that, in that rather than being normal function as per the green line, they were deceptively also had inflammation of their heart in addition to inflammation of their blood vessels. So they looked exactly like the clinical phenotype of toxic shock with a wonderfully functioning heart. You gave them 10 mils per kilo and they went along the blue line and they looked a little bit better. And then they gave another 10 per kilo and then suddenly you got poor function. And the sickest patients at the beginning, so this is a chart showing the admissions to Evelina PICU, the first 47 patients. The sickest patients at the beginning who were ventilated, 2 of whom who required ECMO, all of them who were on inotropes, that's the feature that we saw. And they were the sickest group of children that we've had in the entire last 10 months. And I do wonder whether, because they basically got too much fluid and then basically that worsened their heart failure. One of them went from breathing in air to flash pulmonary edema with only 10 per kilo of fluid. So we became more cautious with fluid. Does that mean that some of the children need lots of fluid? Of course. You know, they might have vasoplegia, they might have capillary leak and need fluid, but just real attention to basically being careful with reassessment with each fluid bolus, that of course we all would do anyway, but making sure that we give the right amount of fluid. If we go back to this chart now and look at the ICU cohort from the first wave, you can see that the ones at the beginning were ventilated, and as we were maybe treating them earlier or maybe recognizing them earlier, they were needing less and less respiratory support, and certainly the inotropes came down. Now this chart is flawed in that we took a decision at Evelina. We had 18 PIMS TS patients on the ward at one time, and so we kind of acted as a triage service really, where patients came through PICU, got an echo, and so that's why suddenly not all of those patients were on inotropes. But the impression from our team and I notice I say impression, was that this improvement, this rapid improvement in how they were managing, was due to earlier presentation, which you've kind of heard about, earlier recognition, less fluid, but also immunomodulation. And if you look at the UK PICU initial cohort, and this is from Patrick Davies' collaboration with lots of PICUs across the country, the length of stay was 5 days across this cohort, which ended collecting data here on May 10th. But actually, by the end, patients were flying out, and often they were on significant amount of inotropes, but those inotropes melted away within 12 hours. And I think that that is different. I think that, you know, with research and the need to study different immunomodulations, that's important. But for the clinician at the bedside, there was a rapid improvement in inotrope score and also in the clinical state of the patient. So if they don't need PICU, if they're well, if they're tachycardic, did they really need to be treated with anything? And again, this is the context, is that this is from one of our first 10 patients where they had a significant coronary artery dilatation after being actually one of the better patients on PICU and flying through. So the well child on PICU ended up with a significant coronary aneurysm. And obviously the cardiologist will talk more about that. And maybe even children are dying outside of PICU. So the context was, oh my gosh, these are fit and well children who are dying, not just in PICU, but maybe in the community. So that's the context that we went into this. And I think it's also important to look at the context of what we did know about COVID. I mean, how could I have been so silly to flippantly say in a ward round, oh, this is probably just a Just Eat delivery driver who, cook who hasn't washed their hands. Obviously now it was due to COVID. But I think we need to learn from the adults, and very much the learning from the adults was that, you know, COVID is about hyperinflammation. Our adults have seen a high rate of immune thrombosis, where they have increased thrombus in small vessels, so causing small pulmonary embolus, increase in DVTs. Our ECMO cohort in adults is one of the biggest in Europe, and they are requiring huge amounts of heparin, clotting circuits off. So seeing that there's this incredible inflammatory response, so of course it makes sense to treat with immunomodulation. And so now if you layer onto our admissions in that first group, and I'm aware I'm still talking for now about the past, but I come on to now very shortly. At the beginning, we were treating them in the black as septic shock. So they were getting refractory, inotrope refractory shock and then getting hydrocortisone. But after we saw these coronary aneurysms and we decided, well, this is hyperinflammation, our team treated these patients extremely hard with immunomodulation. So Kawasaki doses of aspirin, methylpred at stonking doses, and then also immunoglobulin. And as we saw side effects and as patients improved, we've reined that in. So that currently, where are we now, is that a patient requiring inotropes in PICU would get 75 milligrams of aspirin, low molecular weight prophylaxis, and I'll come on to thrombosis right at the end of my talk. And then methylpred 10 milligrams per kilo once a day for 3 days, a maximum of 1 gram, although there's lots of discussion about that maximum dose. And then the immunoglobulin is randomized control trial, whether they get immunoglobulin or nothing. And then IL-6, so we tried different immunomodulators, which Nick Wilkinson can talk about, but we've settled on tocilizumab, which is also randomized in the recovery trial, which I will mention. That's where we are now. Now, what are the side effects of these drugs? So within our cohort of 47 patients in the first wave, a smattering of ongoing PIMS TS, which reflects Elise Randall's slides from the previous talk, and now 19 patients admitted in this current wave through PICU. These are the things that we have seen. I'll talk about bleeding when I talk about thrombosis later. But the methylpred, we see hypertension and hyperglycemia, much less now actually that we limit it to only 3 days. We were giving 5 days back in April, May. And we've had one child with PRES as a result of hypertension, and one child who, by all accounts, became psychotic, probably due to the high dose steroids, which is a recognized side effect. But by reducing the steroids, we're hoping that we get less of these side effects. And that's where the discussion comes about what your max dose is. In terms of tocilizumab is an IL-6 immune modulator. And I'll be honest, we haven't actually seen side effects of this drug. But the people who have seen it is our adult team, which have been using it in hundreds of patients since May. And they have noticed huge amounts of secondary bacterial infection. It's very difficult to pick that apart from the fact that patients are closer together, ICU nurses are being shared between patients. But definitely the bacterial infection rate has gone up significantly, and they're seeing bacteria that you wouldn't normally expect to affect patients who are immunocompetent. So I said about immunomodulation, but actually TOC, although it doesn't have immediate side effects that you notice at the bedside, definitely does cause immune suppression, and it lasts, I'm told, a couple of months in terms of that immune suppression effect. And then immunoglobulin is a fluid overload blood product, and we're very much using this less, and I'm preferring methylpred, but that's our center preference. So in terms of the complications, Elise has already mentioned about red herrings. Just to say, if you have one of these complications and the child is sick from PIMS TS, then I think you can probably, explain it. But it's quite hard to explain complications if they actually don't have PIMS TS and they have one of these other pathologies. So is this just reflective of Evelina? So this is the same paper that I mentioned earlier by the UK group of intensive cares, so 70 patients, and they looked at what happened over this first cohort. And you can see that what happened in terms of treatment was it started off with patients receiving treatment for sepsis, and within less than a month, you now basically had all patients receiving IVIG, almost all patients receiving steroids, and then antiplatelets and biologics. This wasn't due to publications. This wasn't due to anything else other than communication and sharing information. And if you look at that shared information, so myself and Ben Griffiths, who's escaped to Doha where they don't have any COVID and he's sunning himself on a beach, we looked at the guidance across the UK, and that change in practice was then reflected in ratified guidance across trusts where people were basically advocating giving IVIG steroids without clear evidence, but feeling that this was the right thing to do. And just a shout out to Ram, who, when we were writing this paper, which is not yet published, but hopefully will be in Pediatric Critical Care Medicine, he absolutely hates the word consider in guidelines. I mean, I can consider myself an amazing dancer. Anyone can consider anything. So for guidance, it doesn't really help. But equally, on the other side, we're kind of mandating you must give IVIG, you must give steroids. And actually, these have all changed from now to from then to now. And finally, well, not finally, but finally, in terms of immunomodulation, from what we looked at in that first cohort. So this is the paper that hopefully will be published soon. We said, well, did any of these things work? Huge limitations to the study, but what we've done is done our best with Andrew Prell, who's an absolute legendary statistician, and they basically looked at different combinations of treatment to see, did the biomarkers respond quicker with each of these treatments? And the short answer is no. So 12 patients had no treatment. They weren't less sick. They were actually in the slightly earlier cohort. So from looking at 70 patients, which is limited statistically, we couldn't identify that there was any benefit to any of these treatments. So what's needed? So the recovery trial in pediatrics is a very complicated trial to get your head round. But essentially, in the first wave of treatment, you can randomize a patient to methylpred or no additional treatment, immunoglobulin or no additional treatment. And then the next phase is to tocilizumab to no additional treatment. This clearly is the way forward scientifically. What do we do if we have a sick patient who's requiring escalating inotropes in Evelina PICU? We give them methylpred. Okay, that's honest, you know, and you know, when I have conversations with colleagues around the country who are probably, you know, well, not better scientists than me, I'm not a scientist, who are scientists, to go, John, just don't give them the methylpred, you know, randomize them in recovery. My bias is that I think that the methylpred causes good immunomodulation, and I think that these children need immunomodulation if they're on inotropes in PICU. That's my bias. And this study actually allows this to do this. So it allows investigators to use steroids or IVIG as standard care if deemed necessary. So we're not doing anything wrong in the trial, but it's just that the standard care at Evelina for a sick patient is to give the methylpred. So is there anything else? Is there any other studies that might show an answer to what is the best immunomodulation? Just the best available treatment study, which is coming out of Diamonds and Mike Levine's group, is recruiting. So just finishing up with thrombosis and bleeding. And while I don't know what the best immunomodulator is, I think that there is something really interesting in COVID and also in PIMS TS about thrombosis. So this is again pre-published data, but submitted to the Journal of Thrombosis and Hemostasis by Jeff, who's an absolutely fantastic hematology reg. And he trawled through, respect him, all of these notes and looked at all kinds of things, with notably looking at things like platelet CRP, fibrinogen between groups who developed thrombosis, of whom there were 5 out of 68, and looked for differences. And essentially, even though you have high CRP and high fibrinogen at baseline with a median fibrinogen of 5.9 on admission, there wasn't any statistical difference between the groups, and actually they looked pretty much similar. The only values where there was a difference between those who developed thrombosis and no thrombosis were the D-dimers and the ferritin. So the ferritin again may be suggesting inflammation, and obviously D-dimers reflecting ongoing thrombosis. So, you know, and I think this does colour myself, again, bias, that if I see a patient with high D-dimers, then I will look harder for thrombosis. And then against that, there were 2 patients with bleeding. One patient where it was an iatrogenic injury to the femoral artery when putting in a central line. So that, I guess, was avoidable. And also there was IV heparin running at the time, so we really should have stopped that. And the other patient, the bleeding was actually a bleed into a cerebral infarct. And that patient also developed IVC thrombosis. So the correct treatment for that patient definitely was anticoagulation. So in terms of the summary of our ICU treatment, it's a bit black, really. 10 months on, I can't give you the answer, but actually I take huge kind of respect for the UK community in getting recovery done, in the collaboration across the paediatric critical care units to share data. And actually, I think there's real hope that we will, you know, refine this very quickly. For us, it's still about organ support. It's very much about the importance of assessing the amount of fluid when they come into ICU. And I think that it makes sense to immunomodulate and anticoagulate, although I don't have evidence for that at the time. And in terms of the therapy, I think that if you can give less doses of things, then actually you probably avoid the worst side effects. And I just wanted to say thank you to Evelina, the entire team, but also to the UK critical care team, who many of whom I've got to know through this time much better, just through kind of sharing knowledge and information. Thank you.
Wonderful. Thank you so much, John. So just in the interests of time, rather than going through the questions that have come in, John, if you have any time to stay on, there are a few for you. I think Marilyn's been trying to address them, but there are a couple in the chat.
Okay.
We'll move on to the next speaker.
Thank you.
Thank you very much, John. Dr. Marie White, who's a general paediatrician at Evelina London Children's Hospital. So I'll pass over to Marie now. Marie, are you able to share your slides?
Yes, just bear with me. Just trying to get you to see that. Great, hopefully you can see my slides.
Perfect, thank you.
So good afternoon, my name is Marie White and I'm one of the paediatricians from the Evelina, and I'm going to be talking about PIMS-TS, the multidisciplinary Evelina experience on behalf of the whole general paediatric team here at the Evelina. So I'd hope to just give you an overview of our Evelina cohort. You've already heard from colleagues, so Shelley and John here in PICU, but also to talk about our management focusing on the multidisciplinary team and what lessons have we learned when we plan for a second surge. So we've already heard from Shelley about the first cases of what we thought was toxic shock over that first weekend, and I was the attending consultant on for that next week. And we saw the cohort of this PIMS, which we now know as PIMS-TS, which led to the NHS England alert, our subsequent RCPCH guidance, and then the cohort that Shelley published in the Lancet. And then we saw various cohorts in the USA, in Italy, in Europe, that have been published. So looking at our cohort, we saw over 18 in the first wave in up to July to 2020, and I've had over 100 up until January. And our median age is 9 years, but we really did see a full range from 2 months up to 17 years with a full spectrum. So as we've heard, the slightly younger cohort being more on the Kawasaki spectrum and the older cohort having more signs of myocarditis. What was very unusual is that more than half were admitted to PICU for cardiovascular support, more than half were male. And as we've seen, that there was a high proportion of children from Black African and Caribbean backgrounds. And it's really nice, the ISREC study has really shown how broad the symptoms are of children presenting with PIMS-TS, and I think this is reflective in our cohort. The very non-specific symptoms here, which are demonstrated in the purple box. So this graph just shows all the children in the ISREC study who were admitted in the UK who had positive SARS-CoV, either acute or IgG. So the respiratory is the acute COVID, there's a neurological presentation, but this purple box really just represents how broad the symptoms are, non-specific. So headache, myalgia, sore throat, sort of a lot of GI symptoms of vomiting, abdominal pain and diarrhea, and then more than sort of mucocutaneous signs of rash, lymphadenopathy and conjunctivitis. And really how this did provide us with the diagnostic uncertainty. So we had lots of children presenting with fevers and very high CRPs. And some of these children did go on to have PIMS-TS. Some had just normal conditions, so pyelonephritis, sepsis, appendicitis, pneumonia. And then we had this grey cohort, which were very difficult. Some of them ended up having PIMS-TS, others may have had underlying other conditions. Some children went on to have other inflammatory conditions, so still disease, macrophage activation syndrome, we had the leukemia, but also we've talked about the red herrings. So we've had children who have presented with appendicitis, who've had a normal appendicectomy, who've gone on to been diagnosed with PIMS-TS, and then also quite the opposite, children referred with PIMS-TS who've had a perforated appendix. I think this diagnostic uncertainty really highlights the need for oversight, and us as general paediatricians are in the perfect place to be able to do that and to be involved in the decision making, which has evolved as part of the multidisciplinary team, and how this diagnostic uncertainty just proved to be a real challenge. So we've already touched on the management and how the MDT is key, but also that it was an evolving process. As John Lee has just said, we initially were very aggressive with our steroids and doses, which in time we have reduced. But when we look back at our cohort, over 2/3 of the 80 patients in the first wave were treated with IVIG and steroids. We have to remember that we're obviously seeing the sickest cohort and sickest proportion. A lot of these children did present either through IED or were transferred in through STRS to our intensive care unit. So about 2/3 had IVIG or methylprednisolone or both, and about a half, just under a half, were given one of the biologics, which I know Nick Wilkinson I'm sure will expand on. But also looking at the other medicines that we're treating with, so aspirin. Sort of these children went on to have coronary artery aneurysms, dalteparin because they're in a prothrombotic state, PPIs because a lot of them are on high dose steroids, and vitamin D because we know of its important role in immunity. But because of the side effects we were seeing initially of the steroids, we developed guidelines where our renal colleagues developed guidelines for steroid-induced hypertension in PIMS-TS. And so it was very much an evolving process as we were dealing with a new condition. But importantly, we're now recruiting to recovery to try and determine the best management. I think seeing how our teams evolved and the management involved really highlighted the number of teams involved, with our colleagues in the emergency department helping to stabilise them. In our 11 o'clock PIMS-TS meeting, we have an amazing representation of all the different teams, from cardiology, infectious diseases, rheumatology, intensive care, but also our allied health professionals, including our nurse practitioners and us in general paediatrics. But also we've seen other complications. So we have our neurology colleagues, endocrinology helping with our vitamin D, hematology, psychiatrists, radiology, pharmacy, but also how that then interacts with referring hospitals, the wider community, but trying to keep the child at the centre of all of this and making sure that the decisions that we are making are communicated clearly to them. So we have developed local guidelines, really focusing on initially just the normal resuscitation, ABC management of a sick child, but particularly looking at signs of shock, fluid overload and cardiac instability as we have seen in these children. And as we've said, the majority we're trying to recruit to the recovery trial, and then ongoing management with methylprednisolone, IVIG, plus or minus biologics, which are all discussed in our multidisciplinary team meeting. So follow-up has been a real challenge and brilliantly coordinated from our infectious diseases and cardiology colleagues, but was by no means an easy task. We had to quickly develop a patient leaflet about a new condition with a lot of uncertainty. And one of the infectious diseases CNSs helped develop this very quickly. So we had some information to be able to give parents as to what to look out for and when they'd need to represent. We saw a high proportion with coronary artery aneurysms, and they've had to have ongoing follow-up in the PIMS-TS follow-up appointments. But also psychology was a really important part of their follow-up. So we had a very large cohort of children and teenagers who were admitted to the intensive care unit who were awake, and this had been quite a traumatic experience for them. Often they're awake, particularly there was one time a group of children similar age, similar ethnic background, who were all awake on inotropic support. And I think they came down it was quite a scary environment, but also quite traumatized by it. So offering them all psychology support and making sure that we're giving that as they're discharged. So what were we expecting? We're already seeing increased number of PIMS-TS, and this is the US data which showed we've already seen we're expecting a second surge. And how can we plan for that? So in the first wave and the wave, and even now, we have the challenges of redeployed staff and the limit of what we can provide in our HDU. So we managed, in the first wave, we restructured our ward. We had an entire dedicated HDU and PIMS-TS team. And at that point, we implemented a daily PIMS-TS MDT meeting, which is ongoing and very valuable. We've managed to develop local guidelines for the management and referral pathways, and it's important as these change that these are communicated throughout the London networks. But we're also more experienced. We're using research to try and help determine the optimal management, and also using the resources that we have. So we know that a lot of these children need central lines for recurrent venipuncture and all the medication they need. So we've already got in place a way of scaling up line insertion, preparing for the second wave. But also, this is a condition that can be managed by general paediatricians and definitely should be. So now we're only transferring those who are clinically unstable, who are needing STRS or the intensive care input, or those needing specialist input, including cardiology or for an MDT review. So this is our current local referral pathway, and very much focusing on those, so the ABC resuscitation, and those who are unstable should, as they would do normally, go through STRS referral and triage. But those who are stable should be managed locally, and within hours, referrals go to our paediatric infectious disease team, and out of hours through the general paediatrics, and all of which can be discussed at our daily meeting at 11 AM. So we have a way of initially discussing our patients within the Evelina, and then for external hospitals can dial in as needed to discuss patients who have already been referred. So what have we learned? We've got similar challenges. So we have redeployment, we have difficulties with trying to manage the number of patients we may see, but hopefully trying to streamline our management and referral pathways will make this a clearer process. PIMS-TS can and absolutely should be managed by general paediatricians, and I think having that overview is absolutely key, particularly with the diagnostic uncertainty as we see, but with specialist support or input as needed. But really trying to focus on patient-centred care delivered by the multidisciplinary team, recruiting to research where possible, and ensuring that we're collaborating and sharing our data as we are brilliantly this afternoon. And I think listening to patient feedback is absolutely key. And I'm really delighted that a mother of two boys who have been admitted to the Evelina, Emily West, has very kindly agreed to share her story about her experience of what it was like having two children with PIMS-TS in the first wave in last year and also in January. So I'm delighted to be able to share that with you. But I also just like to thank the entire PIMS-TS working group. As you can see, we have a number of teams and a lot of specialties who have input with our PIMS-TS patients. So it's a huge thanks to all of the teams here at the Evelina for all of their input.
Thank you so much, Marie. It was really great to hear from you. And thank you for teeing up the next speaker, who's our parent, Emily. Just before we move on to onto the video, I just wanted to say I can see that we're getting close, very close to the limit of attendees, which is 1,000. So I'd just like to reiterate, and I did put in the chat, that the Facebook live streaming is open to anybody who's got an nhs.net account. So please do encourage any colleagues who you know are trying to get in to use that. I don't think we're going to be able to get our attendee list bigger than 1,000, I'm afraid. So please do encourage them to use Facebook, and we will make recordings available afterwards. So I'm going to share a video of Emily West, who, as Marie said, is the mother of 3 boys, 2 of whom have had PIMS-TS in the last year, both of whom were treated at Evelina London. And I won't give spoilers for how it's gone, but hopefully you can see that we're all smiling. So it's good news. So I will just share my screen and start the video in a moment. Here we go.
Hi, I'm the parent of Lenny and Alfie West. Both boys have been unfortunate enough to suffer with PIMS-TS. Lenny was back in May. He presented with, he started being sick in the morning, and then he had a temperature, and then he had pains in his belly. And because we hadn't been anywhere, I was convinced it was his appendix. So I took him to my local hospital. Very quickly, they was amazing. They knew that his body was quite shut down and they needed to get fluids into him. I think straight away they spoke with the Evelina because they recognised that children were getting sick with some sort of inflammatory thing. So they kind of like, they couldn't tell me for sure, but they was on the ball. They knew what we was doing. We spent a night in the hospital there where they was trying to get some fluids into him because he was just so poorly. Still quite chatty in himself, but just really tired and just didn't look very well. The next day we was taken by intensive care ambulance up to the Evelina hospital. That was quite scary in itself because they kind of came, they was teamed up, and when I see the ambulance myself, I thought, is my child sicker than what they're telling me? It was quite scary, and they blue lighted us all the way there, which was fun for Lenny. For me, I'm thinking in the back of my mind, what is going on here? Up on intensive care, it was amazing. Doctors came to see us and they said, look, we're finding a lot of children having these symptoms. We think it is a kind of reaction to COVID, that a few weeks after they've had COVID or been in contact with COVID, that their immune system's trying to find something to attack and there's nothing there, so it is just attacking their own body. So from there we went down to the ward, and again the doctors were like, we are trying all these different drugs just to see what happens. But to be honest, I was a bit in auto drive at that point. I was kind of like taking it in a little bit, but it was just a bit like just looking at a sick child thinking, please just make him better. They gave him the first, I think they started Lenny on steroids, which kind of worked for a little while. We picked up a little bit, but then the next day he went downhill really bad. He had this excruciating headache. Like, Lenny's never really suffered with headaches before, and he was literally doubled over in pain. In the end they gave him some morphine just to kind of like calm him down, and at that point he was like begging me like just to make the headache stop. So I agreed to give him the morphine just to kind of like give him some rest and get the pain off of him. The doctors came to see me and they said, look, what we have tried is not really worked, so we're going to try this next form of treatment, which should kick it out of his system, like turn his immune system off for a little while and reset it, so he will start showing improvement. So yeah, he had the next improvement. He slept a lot, and obviously because of the morphine as well, he slept a lot, and the next day he actually woke up and had a lollipop. He looked awful. His eyes were all sunk, he was pale, but that was the first time in a few days. I'd lost all my days, so I don't know what day that was on, but I think we'd been in about 3 days and he had a bit of a lollipop. So for me to see him eat was just amazing because my kids love their food. He then, after that medication, it just kind of got better and better. He wanted me to order him a pizza in, so I was just like, whatever you want to eat, you can eat, I'll get it for you. And he just picked up really, really well afterwards. I was kind of like just waiting for a bit of something else to go wrong. Like I wasn't convinced he was better because he still looked poorly, even though he was looking better. And then before we knew it, he was being sent home. He had lots of heart scans, which was scary because you're thinking, what are they looking for in his heart? He had to have a CT scan on his head because of the headaches he was having, but I think that was all fine, and a lot of ECGs to just check that his heart was working properly. I mean, that in itself is scary because you think as a parent, what if they're looking at his heart? Like there shouldn't be anything wrong with his heart, and the amount of scans and stuff and blood tests they're having is scary. But they was honest and they said, look, we're not 100% sure what this is. We'd be silly to think that it's not related to COVID, so this is how we're treating it. And they did amazing. We got my boy better, and then before we knew it, we was home and he was back on his computer, he was eating, and it was literally like it never happened. With Alfie, he had a positive COVID test around just before Christmas, around the 20th of December, 21st of December. And then I was kind of like worried because they said at the time with Lenny, we don't know what's going to happen if they do come back into contact with COVID, to kind of like keep an eye on him sort of thing. And we'd had many follow-up appointments with Lenny and he was discharged. All his heart scans were fine, all his blood was back to normal, that was fine. He does still get really tired though. Like sometimes I'm literally like, Len, just go to bed. Like you look awful, go to sleep. And he will sleep. He never really gets the refresh sleep and has been doing a reduced time to this. So back to Alfie, he had this positive test, and I was kind of watching Lenny like a hawk, like taking his temperature every day, like thinking, oh, what's going to happen? Like, is he going to get something? Is he going to get sick again? Alfie last Monday morning, on the Sunday, he slept all day Sunday, didn't really eat his dinner, and I was thinking, oh, he's been up in his computer all night, he's too tired to even eat. But early hours of Monday morning, he came up to me, he had a burning temperature, his temperature was 39. I kind of like was trying to get him to sip water, and then he was in my bed, and I was like, come on, let's watch a film together, like trying to make him feel better. And then he had a sleep, and he woke up, and he was doubled over in pain, with pain in his stomach. And I was thinking, oh, here we go again. And I didn't want to seem like I was overreacting, dragging him straight up the hospital, but I'm glad I did. I spoke to my partner, and I was like, I'm just going to take him up to Evelina. I think this is what Lenny had. So I just got him up there, and I said to the hospital, I don't know if I'm completely throwing it out there that it is PIMS, but I'm pretty sure it is. He had positive COVID test 4 weeks ago, and now he's sick. And even the doctors were like, yeah, we're not 100% sure either. So they said to me that he wasn't even showing proper PIMS sign on his blood tests. Like, he's kind of like pretty normal. So there was a bit like, is it a urine infection, or could it be this PIMS? So by the Wednesday morning, they had decided it was PIMS, and they got me to sign a letter to decide what treatment he was having first. I suppose both the treatments worked for the IVG medication and the steroids, but so they're just trying to work out what one works, how it works better, what way around it works better. So they started him on that drugs, which took a while because he doesn't have very good veins. In the end, he had to kind of have a pin put in his neck, which I was a little bit annoyed about, because they were saying about putting a PICC line in, and they said, oh, we only do it on Mondays, Wednesdays and Fridays. And I was thinking, well, this child needs one quite desperately. Like, you can't get blood out of him, you can't get medicine in him, his veins keep collapsing. Just kind of, can you not just get that PICC line in him? Anyway, this brilliant doctor came down and managed to get a line in his neck, and we said that we'll be going for a PICC line in the morning. So we managed to get this medication in him, and the next morning he was sitting up in bed, he was looking at his phone, he looked amazing. By the afternoon, he had a temperature again of 40, and he was again completely out of it. And I was thinking in the back of my head, come on, let's start the steroids, you can do this, like, start the steroids and that. And I just wanted to tell the doctors, like, just do it, like, that's what's going to make him better. But I'm not a doctor myself, so I was just kind of like waiting for it to happen. Anyway, 2 o'clock in the morning, right, we're starting the steroids. I was like, right, brilliant, that's amazing, now we're going to get my boy better again. So yeah, that was that. They got the steroids in him. By the next afternoon, he was up, he'd had a shower, he was sitting and played a couple of games of cards with me, and then he was still very sleepy until the steroids had finished. Once the steroids had finished, he was kind of getting his appetite back a little bit. He wanted some chicken nuggets, so we got some chicken nuggets for him, and that's it. He was on mend. His oxygen was a little bit low, so I had to monitor that for a little while. So I was just thinking, right, the PIMS has gone out of his system, we just need to make sure that's all fine. And then yesterday, Sunday night, I said to him, come on, let's walk around for a little while, we need to make sure your oxygen's fine, because it's going to be the only thing stopping you from going home. So we got up, we had a walk around, and amazingly his oxygen was 99, like, all night, which was brilliant because it was dropping down in the 80s. And then he was home last night. He was playing on his computer, he was shouting at his friends, and I was just thinking, this is great. Like, the hospitals are just amazing. What they do is amazing, but you just have to be prepared for the roller coaster. I'm the sort of person, I go into autopilot. I let the hospital make the decisions. They know what they're doing. Although I did think he could have started the steroids a little bit quicker. They know what they're doing, and they got both my boys better, which is amazing. And I just can't believe how unlucky I am. I will be watching the third one like a book though. just to see. Alfie's got a few follow-up appointments, as Lenny did, a few heart scans and a few blood tests. But I'm hoping, and some aspirin to take. So a few weeks, and I know it's all going to be done and dusted. So they got through it, and I'm now a nervous wreck, but it's fine. They're better, and that's all that matters. Thank you for listening.
Okay, so that was Emily West, and I'm just going to open up. We've got a short video of her two of her sons rather, Lenny and Alfie. So I'm just going to share my screen for that. It's just a short snippet, but I think it's really good to hear from them.
Hi, my name's Lenny, I'm 13. I had PIMS back in May last year. It was scary and I had a really bad headache, but I'm all better now, so yeah, good.
My name's Alfie. I had PIMS and I got out of hospital yesterday. I was really poorly. I feel better now. Right. I didn't like they couldn't get blood out of my arm, so they had to put a line in my neck. And Alfie is my pain. And she's the best.
And feeling better now?
Yeah.
So,
I feel better now.
There we go. So I hope you agree. It was really good to hear from them. So our next speaker is Dr. Ming Lim, who's a paediatric neurologist at Evelina London Children's Hospital. So I will hand over to Ming now.
And it's at this point I realized that I can't start my camera.
Oh. Don't worry, as long as we've got your slides, that's well, it would be lovely to see you, but the slides are very important.
Correct. I'm going to try and see if this, and you can see the slides?
We can. Can you make it so that they're full screen?
I will try.
That's it. And then if you go up into, can you see where it says display settings towards the top?
Yeah.
You click on that arrow. Perfect. And you want, yeah, that one.
Great. Okay. And you can hear me, yeah?
We can. If you just click on that swap presenter, I hope that will make it a full screen then.
Oh, hang on. I thought I'd just done that. Let me just stop share and start again.
Sorry, Ming. Perfect.
Okay.
Thank you.
Great. So thank you very much. And it's always humbling to come on after patients and mothers presenting. And I'm going to talk to you today about the neurological impact of COVID in children. And the few key things I will talk about, and hang on, the thing is stuck today. Oops, too much. It's on the neurovirulence of COVID, and thinking a little bit about how severe the neurological symptoms can be, as opposed to how frequent they are, which is perhaps neurotropism, so slightly different. Allude to the spectrum of children presenting with childhood, neurological syndromes. If there are specific, characteristic syndromes we can recognize, and of course, possibly touch on the sequelae of COVID in children. And I think this is one of the best reviews of neuro-COVID, so to speak, in both adults and children. And when you look at any sort of neurological syndrome following a viral infection, the things to think about are sort of, one, the mechanism, i.e., is that due to direct infection? Or is it due to a para-infectious mechanism, meaning that as the virus infects the brain, it is the inflammation, that causes the symptoms. And of course, what we neurologists see more frequently is what we tend to call the post-infectious component, meaning that you've had the symptoms weeks and weeks ago, you recover from the infection, and then the immune system is triggered in a secondary way. And the syndromes generally do correlate with the mechanism, although in COVID, I think it's less clear, and it may span through a wider sort of presentation. So for example, the encephalitis may represent a direct infection or a peri-infectious sort of mechanism. And of course, not forgetting that when the immune system gets upregulated, the systemic inflammation can also trigger inflammation. And so that is, as I said, becomes less distinct. Myelitis is a common presentation in adults. SSADEM, which is we're more familiar with in children. GBS, I saw in a question earlier on about the presentations here, and I'll tell you a little bit more about that in children. And of course, in the adult world, there has been a lot of concerns about cerebrovascular disease. And do we see that in children? So we'll touch on that as well. If one was to look at the virus associated encephalopathy, this is the general spectrum that you might have heard of or be familiar with, from the mild end of the spectrum being the mild encephalopathy with reversible splenial lesion. And that's the bit that we see perhaps the most radiologically. And as the spectrum becomes more severe, there is more gray matter sort of involvement as such. So children have seizures, you have acute necrotizing encephalopathy, and on the opposite extreme, you also get the systemic manifestation of this hemorrhagic shock encephalopathy, and usually of high mortality and morbidity. Whilst the intrusion into the brain is maximal at the end of the spectrum, there is also a huge, systemic component in a lot of the inflammatory responses. And you will have seen this in influenza and a whole range of other, viral infections. So in that review that I mentioned earlier from Tom Solomon's group, they recognize that when compared to other viruses, the coronavirus, particularly SARS and MERS previously, were of low tropism. Tropism meaning that, the virus doesn't get into the brain as much, as I mentioned earlier as well, because it's difficult to be sure whether some of the brain symptoms are directly related to brain viral infection or inflammation. They are usually sort of referred to together. But despite the low amounts of infection in the brain, because of the numbers of patients that we're going to see with COVID-19, the numbers will still be high. And of course, you will see there that when they did the paper in September, the number of UK cases were only at 246,000, of which it is at about 3.5 million now. And, the projected cases based on even a sort of neurovirulence or tropism of, or percentage of less than, 0.01% amounts to a sizable amount. Do we see that in children? We'll come back to that later on. So this is the distinction between the tropism and the virulence, meaning the severity. There is a lot of evidence now that the primary sort of mechanism of brain inflammation or brain pathology, or the neuropathogenesis of SARS-CoV-2 is hugely influenced by the systemic inflammatory response. This is a nice review from, again, Tom Solomon himself. And the systemic inflammation then triggers, the adaptive immune system attacking the brain, alongside upregulation of the innate immune system, within the brain. Alongside this, we've talked about all the sort of prothrombotic sort of cascade being activated as well. And of course, there's the immunothrombotic cycle, meaning that every pro-inflammatory, response is also, prothrombotic. And then, hidden somewhere there is the sort of virulent side of things in terms of the direct, viral infection. And although there are some evidence of, 1 or 2 cases whereby, there is PCR, positivity, it remains unclear whether it is directly invasive. And of course, if you were a neuro ID a specialist, you would argue that, if the blood-brain barrier was so damaged in the first place, then of course, viruses may just, appear in the CSF just from escape from the leaky barrier rather than invasiveness as such. But nonetheless, these are the few pathogenic mechanisms of the neuropathy of the neurological presentations in SARS-CoV-2. And it was our colleagues at Great Ormond Street that first recognized the pediatric sort of phenotype comprising of predominantly central and peripheral nervous system involvement. So these are children with, encephalopathy and peripheral nerve involvement, almost like a GBS-like picture. And some of these children also probably had a myopathy. What they also recognized that although quite significant and had radiological features of the splenial lesion that I'll show you a little bit later, the burden of neurological disease was not big. In the cohort of patients that they had up till that point of about 30 patients, 4 patients had this phenotype, so about 10 to 12%. What they also recognized was that predominantly most of these patients were perhaps due to the systemic inflammation, that was driving the process rather than specifically related to viral, infection. And of those small, they again recognized that half the children made very good recovery, but the other half at about 3 to 6 months from follow-up still had significant cognitive sequelae, hinting that, the inflammatory process may have a longer term sort of outcome. This, Marie has shown you earlier that it was at this time that we were starting to come to terms with this hyperinflammatory syndrome, and certainly the patients presented in the cohort at Great Ormond Street all had some form of, hyperinflammation, as well. So at the time, we started to look at our cohort of children. You saw from Marie that there were about 80 patients, of which we had good data on 75. All were fulfilled the RCPCH criteria for PIMS-TS, and we retrospectively looked for the neurological symptoms after having recognized that they were likely to be possible based on the GOS experience. We looked specifically for features of encephalopathy, seizures, movement disorders. So these are typical psychiatric features, and also neurological deficits. All these are features that you would generally see when the brain is inflamed. And of the 75 children, 9 children had neurological symptoms. So this 12%, very similar to the data from our colleagues at Great Ormond Street. The common features were one, of course, of encephalopathy, the behavioral change, which included patients with psychosis, and the focal neurological deficits, of which both of them had strokes, and both were highlighted already in earlier presentations. And new focal seizures is another presentation in our cohort, and all that you saw there had systemic features of inflammation manifesting as fever, cardiovascular symptoms, the high predominance of GI, and a small proportion with respiratory symptoms. So what are the radiological features of COVID, but specifically PIMS-TS? And this is this very characteristic splenial hyperinflammation here. This is probably myelin edema in the splenium, and this is the bit that decussates, and there appears to be a very specific feature. Occasionally, you see patients with more cortical involvement, and they can be subtle. And of course, the much more sort of impressive change and does signal a much sicker child often is the stroke. And this is the child that unfortunately passed away after malignant edema from the stroke. And this is the child that John mentioned earlier with the hemorrhagic conversion from the infarction. At around this time last year, the group at Great Ormond Street, in collaboration with a wider international group, also published the neuroimaging features of 38 children with a range of problems. And you will see there that the features are reflective of the types of mechanisms that can trigger inflammation in the brain, or post-infective syndromes in the brain, ADEM being a characteristic one, myelitis being the other, remembering the sort of AFM sort of picture of enterovirus. And the cranial nerve enhancement is a specific feature of the imaging change. And it's important that some of the cranial nerve enhancement are asymptomatic, meaning that you see it, but you do not necessarily have cranial nerve pathology, symptoms, that is. So you and the other group, of course, being patients with PIMS-TS, and these are the splenial changes that I mentioned. And in some patients that you could identify or found sections of muscles, there's definitely evidence of inflammation in the muscles. And then the big other group is the patients with cerebrovascular accidents. So these are the stroke patients. So pretty much mirroring the clinical syndromes. So there are no specific syndromes that is unique to COVID-19, but other than the cranial nerve enhancement and the more characteristic splenial lesions, although you see that in a range of other viral infections. So what happens to this group of children? You already saw that from the very limited short follow-up, patients presenting with neurological sequelae, with neurological symptoms and a syndrome at presentation, half of them recovered. And this is very much what we saw as well, that some recovered completely, so much so that you wonder how they might have done so despite how sick they had been. But there are clearly some with some sequelae. And I know that Owen Miller, my cardiology colleague, is going to touch a little bit on the sort of wider longer term outcome across all sort of systems rather than just neurology a little bit later on. So I won't mention much more about that. What we were also interested in was whether children with neurological symptoms presented slightly differently or had slightly different demographic features compared to those with neurological symptoms. And there clearly was no difference. You have seen already the sort of high ethnicity representation across the group, both in COVID and also in PIMS-TS. Patients had the weight as a risk factor. So this was equally represented in both groups. But what we were quite surprised to find was that patients with neurological symptoms certainly had higher inflammatory markers at presentation, or this is what we measured to be the highest inflammatory marker pre-starting treatment. And this was acknowledging that it's a small cohort, particularly the 9 patients. The differences were statistically significant in CRP, procalcitonin, and sort of D-dimer. And this is just another way to illustrate that. And each parameter is measured or is represented in the panel. But I wanted to show you that the panel on the right are patients who've had residual neurological symptoms. And these were the only 9 patients rather than the larger group across the comparison between the two. So remembering that only 4 or 5 had neurological sequelae compared to the 9 and 66. And that's why we probably find less significance between the group. But even when within the small group, we've certainly identified that higher inflammatory markers predicted a slower recovery in these patients, remembering that they were only followed up at 3 months, including ferritin. So I think this, to me, signals that we certainly have to watch inflammation very significantly, and we have to follow them up for a lot longer. And this certainly dovetails very nicely to one of the studies led by a colleague at Great Ormond Street, Yael Hakohan, and I'm the sort of co-lead. And this is one of the few examples, I'm told, of the 3 charities, both at Great Ormond Street, Evelina at Imperial Mary's, funding this initiative. And this would be an advanced imaging project looking at how inflammation might influence the subsequent brain growth, of these children. Children will be recruited across all sites to be scanned either at the Evelina or at Great Ormond Street or UCL, with the specific question as to how inflammation alters brain growth, connectivity, and if we can correlate them to the cognitive and psychiatric outcome. In the last 5 minutes, I just wanted to highlight that up till now, what we have is information from relatively, small cohorts, which may of course be pretty, biased. But what is very clear out there is that there are larger initiatives going on, and this is across the BPNSU, which is the Pediatric Neurology Surveillance Unit. And a lot of you would have reported patients to the Corona Nerve study based at Liverpool. Rachel Neen, my colleague, and Stephen Ray, who's one of the fellows, is collecting neurology cases. And you will see that the numbers are not, massive. And we already know that in terms of, the neurovirulence in children. The data clearly is not robust enough to work out an exact, percentage or point incidence, stroke prevalence of neurological problems in children after COVID. But the spectrum that you see there in terms of the presentation is very similar to what's been reported in adults. And if you were to group them, and the reason for me not being more specific here is that because the larger group is still looking at defining and making sure that the designation of these patients are correct. But broadly speaking, the types of cases that we see are children with a neurological syndrome as a worsening of the underlying neurological condition, but predominantly sort of seizures, patients with epilepsy. There's a group of patients with acute COVID with encephalopathy, and these may be the group of patients that present with raised intracranial pressure that was raised in one of the questions a little bit earlier. A huge proportion are patients with PIMS, TS, and neurological, features, and already showed you that the more characteristic splenial change, occasionally inflammation in the cortex, and stroke. In the post-infectious group, you see patients with chorea, psychosis, GBS as in adults, and demyelinating syndromes. I think one of the key questions we always, ask ourselves is, how relevant is the burden of neurology related to COVID-19, SARS-CoV-2, COVID-19 compared to any other, presentation at that time. And this is the first sort of work, and a lot of you will know that neurological conditions are particularly rare. And as a result of rarity, it really takes an international collaboration to be able to answer such question. And one already exists in terms of the stroke network. And this is now led by Norma Delamini, whom some of you will know used to work at Great Ormond Street before going to Toronto. And what Norma did was she activated the network of all the countries that are already recruiting and reporting to a surveillance of a larger stroke study to identify cases of stroke during this period. And I just want to show you two bits of information from this larger piece of work that is now published. The first is that if you look at the January and February incidents, i.e. pre-peak of COVID, the incidence of stroke is statistically at least not different to the post or during the COVID sort of era. So there's no increase in stroke incidence over that time. So if you have a stroke, as you can see there in those percentages, it is still far likelier to be due to any and another etiology rather than COVID-19, and this is pretty similar or mirrored in the adult data as well. And of course, the differences here between tested and non-tested is that most at the time, at least in the first peak, only 50% of patients who presented with stroke in any of these centers were tested for COV2. And there are evolving data from adults. So there was a nice paper in Brain from a larger UK collaboration showing that the incidence of GBS before COVID and after COVID, remains pretty similar. So the additional COVID burden to neurological morbidity as a result of infection, has not been particularly high. So neurological symptoms or syndrome in children may be only 10 to 15% in a hyperinflammation syndrome. When it presents, it is likely to be secondary to the secondary inflammation systemically. But of course, if you see a patient with PIMS-TS and neurological symptoms, it could signal a higher inflammatory state. Might that mean that you would target treatment slightly differently? Hyperinflammation, as we've shown, over a short period of time may delay recovery and may have clearly longer term relevance on neurodevelopmental and psychiatric morbidity. And of course, I think what all of us is stressing today is that the substantial burden to all presentations still remains, i.e. you still need to think of non-COVID etiology. And Marie had a nice, more colorful version of this, but this is merely to acknowledge all my colleagues who have worked very hard on this cohort of patients, for which we hope to continue to contribute to the growing body of data across London, but sort of nationally as well. Thank you.
Thank you so much, Ming. If you're okay just to stay for a couple of more minutes, Adrienne's got a couple of questions she wanted to direct to you from the attendees.
Yeah. Thank you. Dr. Lim, thank you for that fascinating presentation. We had a couple of questions from clinicians. The first one comes from Sebastian. He asks, do we have any idea if the auditory or vestibular systems are affected? So have you been seeing hearing loss, tinnitus, and balance issues?
Yeah, so we've been seeing non-specific balance issue, particularly after hyperinflammation, and colleagues at Great Ormond Street who have followed the patients up more systematically over a short period of time, Yale particularly, tells me that there are saccadic abnormalities in eye movements, and that to me would suggest that yes, there is a problem, but that would probably feature from the sort of hindbrain, i.e. a cerebellar type pathology, rather than a vestibular pathology in these patients that are specifically sort of ataxic. So I think the answer would be that whilst not specifically a problem with the vestibular system, but unsteadiness